So, ladies and gentlemen, good morning, and welcome on behalf of my co-chair, Covanis, President of IBE, to the Presidential Symposium that, as you know, is a landmark event that takes place at all International Epilepsy Congresses. And the topic for the Presidential Symposium is always a hot topic of high relevance, and of high relevance to both organizations, ILAE and IBE. And Thanos and I agreed that in 2017, the hot topic should be the classification of seizures and epilepsies that have been published in Epilepsia, in fact, just a few months ago. The way we classify seizures, epilepsies, is extremely relevant to our profession, but it's also relevant, especially the terminology, to life, to the lives of people with epilepsy. And that's why really the relevance is very broad. I mean, the best example perhaps is the huge and successful efforts that were made in Korea to change the word of epilepsy in that language because of its negative connotations that reinforce the stigma. The symposium that we will be discussing today will be especially focused on a classification that has replaced the last one, the last approved one, which was in 1989, as you all know. So many new concepts are incorporated. But it's not just that, it's that the way these documents were produced follow the process that the League has now established for the approval of position papers. And that is, they are no longer the product of the work of a group of experts, but because eventually the documents in their draft stage are placed on the website, and they are spread around the world through the modern media, we consult extensively with the community. And this consultation process, as will be explained, went on for years and years. So the documents we'll be discussing today are not the product of a commission, are the product of the work of the entire community. And by the way, not all of you may know that the large majority of people accessing the ILAE website are not professionals. They are people with epilepsy, they are their caregivers, it's the general public. So we have a very distinguished faculty in this symposium, and I pass on the microphone to Thanos, who is going to introduce the first speaker. Thanos?
Well, thank you very much. I would like to welcome everybody as well. And we have four speakers, very well known to all of us, so they don't need a special introduction. And we start with Nico Moshe, who is going to talk with a provocative title, The Classification Wars, a Historical Perspective.
Thank you. Thank you for the kind invitation. And I'm very happy to be up here to discuss something that it's actually something that I learned over the time that I was part of the executive. And the message is, do not get involved with any classifications, because it will create a war. And if you need to have a war, you have to have a historical perspective of what has happened over the years. And the historical perspective can be twofold. One is the older person, me, who thinks that they know everything. But the most important person is the person who's going to follow me, or all of us. And that's one of them is Pooja Patel, whom you see in the corner here, who's a young attending in my institution. And we work together because in order to determine what a historical perspective is, you have to get the opinion of both the young and the old. And it's actually quite interesting. As we work together to try to figure out what it's all about, the classification, we found some very, very interesting things. As Emilio said, most of the people who are interested in looking at this are people who are not necessarily epileptologists. And they can be private practitioners, nurses, pediatricians, internists, etc. And we need to define what we're talking about, which is not easy. We need to classify and keep it very simple. So over the last few years, we have tried to define what is a seizure, and now we classify according to the symptoms and the signs. And this is good for the patients and the caretaker information. And the best thing is, as we take the history, and what has really changed is now we see the seizures. We don't rely on the observations that the people have told us, because, as you know, these are extremely unreliable. So at least for some of the motor manifestations, we can use a visual medium to do that. Then we need to define what is epilepsy, and a classification, and as we will finish, is we're trying to classify in order to have an etiology, to have understand the manifestations and the comorbidities, the treatments and the prognosis. We are neurologists, and we like to make things simple, and not simpler than that, but in reality we make it too complicated because we want to use a dualistic approach. It's either black or white. And we keep on doing that. It makes it easy, but it's not necessarily correct. So we try to separate seizures to focal and generalized, and for the most part, through the history, we have those that we consider the grand mal and the petit mal, and here we have to acknowledge that the French were very influential in public relations because they were able to put the French names in the classification of the seizures. But it wasn't always the case. If you want to read a lot of this information, there are several good publications. One is the book by Temkin, which I highly recommend. It's called The Falling Sickness, and he presents the history of epilepsy throughout the Western Hemisphere till about 1971. There are some other interesting publications. I would like to point out the paper that Peter Wolf wrote on the history of epilepsy, published in our journal, the educational journal, Epileptic Disorders. Another very interesting, very recently published paper is by Christos Panteliadis, where he discusses information from the antiquity through the 20th century. And there are two older books that it's worth looking at. One is probably the first textbook on pediatric neurology by Ford, that I doubt many of you have seen. And the other one is Garrison's History of Neurology, which I bought in 1975 when my institution gave me some money to buy a book. I chose that book, and the first time I opened it was about 6 months ago. But there was a lot of information. So the early steps. We are aware that in about 1050, the Babylonian medical text of all diseases describes seizures. However, and here we have all to bow, and not because I come from Greece, but Hippocrates was really an amazing person. He provided the first scientific monograph on epilepsy. It indicated that it may be hereditary, and if he knew genetic and genes, he would have said that too. He said it affects children more than young people. At his time, many older people were not alive because they were dying relatively young. He also said that males are affected more than females. He pointed out that seizures originate from the brain, an organ of senses, motion, intellect, and he also defined that the causes of epilepsy could be hidden versus evident. I don't think we've gone that far from this classification. We do understand a lot better the etiologies, and we describe them better, but I think he had the finger right on the spot. Erasistratus, 100 years later, described epilepsy as a convulsion of the whole body together with an impairment of the leading function. And what I presume he meant by that is intellectual dysfunction. Areteos, he was the first guy to describe the aura. And he also described 3 different types of epileptic crisis, the early manifestations, then as the seizure slows down, the abatement, and then cessation when it stops. He also likened the bilateral seizures to the movement of a slaughtered animal. Now, that's important if you follow history to know that there was, in the 60s, one animal model of epilepsy which was produced by decapitating a rat. And people were giving a medication to try to provoke the post-decapitation seizure. So the information that we have was quite accurate from Areteos. Celius Aurelianus described two different types, another revelation, the convulsive type and the comatose types. And now in the ICUs, we know how many of them are in subtle status epilepticus, and we call that under a different name, but it was there. The next major player is Galen, and he tried to identify that the seizures were due to a primary affection of the brain. He called that idiopathic or protopathic, and he meant primary, versus an extracerebral cause, and he called that sympathetic, by that meaning concomitant, and later that was replaced by the word symptomatic. He defined also three terms. One was epilepsy, that was idiopathic, and it was located in the brain. Analepsy was originating in the stomach, and cataplexy arising from other parts, which is interesting because now we know that diseases of the gut may be associated with seizures. There is a huge jump of about 1,000 years, and then Avicenna, at least that's what I was able to find, Pooja and I were able to find, Avicenna described that epilepsy can come without an apparent convulsion. That's a very important piece of information. Platerius identified the three galenic types that I described before, but also a major and a minor epilepsy. And his assumption was that the latter was due to complete or incomplete obstruction of the ventricles. Lepoix first linked epilepsy and hysteria, and we wish he didn't do that, but it's there. Stahl separated convulsions to either a complication of some disease or not related to another disease, which is something that we're trying to do with the current classification as well. In the 18th and 19th century, there were several interesting publications. Tissot, who wrote the first modern book on epilepsy, described the seizure types as grand accès et petit accès. He was first to describe absence seizures in a child. Also mentioned syndromes associated with epilepsy. Brought back also the notion that sexual excesses as a cause of epilepsy, and masturbation was either a cause or consequence. Esquirol introduced the term grand mal and petit mal, and it stayed for quite some time. Florent describes cerebral hemispheres being non-irritable, and that's an interesting concept because now we talk about epilepsy as generated in the cortex. In 1823, they didn't believe that the cortex can generate the seizures. Stimulation did not induce movements. It was quite a difference from what they were thinking before. Maisonneuve tried to separate the seizures to idiopathic due to congenital, spontaneous, plethoric, which has to do probably with the body type if you're big, humoral if there is a change in the body fluids, or caused by strong emotions, and sympathetic, which is some form of irradiation from external parts. Delasiov added the term symptomatic epilepsy, and he thought that it was related to some cerebral lesion. Subsequently, in the 19th century, Marshall Hall believed that the site of the seizures was the medulla. And Todd, besides describing thought paralysis, he has a wonderful paper on brainstem seizures. And remember, this is the time that they thought that the cortex was not irritable. Brown-Séquard consider epilepsy a reflex phenomenon, which is very similar to what the description was by Athanasios, that you can be induced by in the brain, the lower brainstem. Jackson was the first one to bring the idea of a discharge of cortical origin. And he also defined as epilepsy for occasional, sudden, excessive, rapid, and local discharges of gray matter. He emphasized occasional, but now we know that they can be quite frequent. He introduced the concept of a dreamy state and related the symptoms to lesions in the mesiotemporal lobe, calling those onset fits, and collaborated with Horsley, and that marked the epilepsy surgery, and introduced a new term, which is focal. Gowers, in his magnificent monographs, separated those as idiopathic and organic, but by now everybody believes that the seizures just occur in the motor cortex. So we are getting back into the dualistic approach, focal or multifocal, and generalized. And then we started the development of epilepsy classifications. Ferret introduced the term epilepsies and distinguished the primary partial and generalized paroxysms. Turner and Binswanger tried to include the idea of it's difficult to pronounce that, physical epilepsy, but I'm not sure what they meant 100%. Then there was a tremendous difference because we had the EEG available to us. Kaufman and Pravdish-Nemesky were the first to associate epileptic attacks with abnormal electrical discharges in the brain. Berger brought the EEG to all of us and described the first pattern of interictal discharges. Gibbs and Lennox proposed the term psychomotor epilepsy. Penfield and Jasper introduced the EEG as a routine method for neurosurgery. And then it was the Gastaut period. And I will get to Gastaut after the next slide, because first I would like to show you how Ford, which approximately just before Gastaut was trying to separate the etiologies, classify the seizures. So he was describing secondary or symptomatic, and he put the term next to it, known. That means we know what possibly caused it. And primary, essential, or idiopathic, which he also, in a parenthesis, says unknown. He pointed out that epilepsies can be cases with early onset and a developmental defect associated with an acquired lesion, and cases that are associated with no abnormalities, and he called that essential epilepsy. He noticed that there was a peculiar inheritance, and we find a lot more nowadays, determined precipitating factors like acquired injuries and other diseases of the brain. And Patrick and Levy came back to the idea that there were pre-epileptic syndromes, the auras, that we now believe that they're part of the seizures. And I promise I'll get back to Gastaut. This is a slide that I will ask a question from the whole group afterwards to tell me the specific day that Gastaut proposed X, Y, and Z. And if you remember that, you will get an award, which is a free flight to Bali next year. So the first one was the proposed international classification of epileptic seizures. And you can see the amazing people who were included in developing the classification. Most of them were people from Europe. And it is highlighted that the Commission stated that there is limited knowledge of the underlying pathological process within the brain, and any classification can be a tentative one. So although we're dealing with classification wars, most of the people understand that there is no war, that we're trying to move forward with the knowledge that we have. Gastaut and Broughton in 1972 made the following points. Most authors confuse classification of seizures to that of the epilepsies. And what we're trying now, and as you're going to hear, is we try to combine those things and separate them as much as it's possible to separate and bring them together when we need to. The classification of seizures is based on symptoms, signs. They thought EEG was very important, although there is a problem that you cannot use an EEG in the emergency room, and occasionally a pathophysiological interpretation. And that was done before any imaging was available. For those who remember, the studies were pneumoencephalograms that will be done. It's not easy. They defined the epilepsies as generalized, or unilateral, or hemigeneralized, or asymmetrical generalized, focal or local, as Penfield and McNaughton wanted, or partial, as Gastaut, Simmons, and Maslin proposed. And then they had seizures that could not be classified. Unknown. Then the criteria for the classification is the accuracy of the description, which was limited by historical perspectives. Most people who watch the significant other or kid or anybody else have a seizure are not going to be very good observers. They emphasized the need for simplicity without sacrificing accuracy, and they also wanted minimal or absence of any pathophysiological undertones. They came up with the classification that we work with for many, many years. They separate them as partial, generalized, unilateral, erratic in the newborn, and although it's not part of this symposium, Ronit Pressler and Elisa Yosovitz and Samir Zubairi are working on developing the classification of seizures in the newborn with the new information that we have available, and those that they were unclassified. They tried to figure out if they can separate it according to seizure frequency, as isolated or individual, repeated, fortuitous, associated with something else that's going on, cyclic, provoked, and then they have status epilepticus. There is, in that book of Gastaut and Broughton, there's a long discussion about partial versus focal. And they emphasized that the term were used interchangeably, and they preferred to use the term partial because it is the oldest and most widely used. Now, we saw that that's a matter of interpretation because early on they used the term focal more than partial, but they also felt that focal may be too limiting. They like the word partial better. They also described the generalized seizures, and they thought that there was nothing be referable to one hemisphere only. They will have motor symptoms which were generalized. They didn't define what generalized were, or bilateral, more or less. And again, that leaves a lot of ambiguity because anybody in the emergency room who does that, if you watch me, is described as having a generalized seizure, but that doesn't mean it's a generalized seizure. They felt that there will be an en masse autonomic discharge. The EEG will show manifestations simultaneous on both sides, and the onset appears to originate at a point of convergence deep in the cerebral structures, with all structures activated at the same time. The terms that came out is that they were centrocephalic by Penfield and McNaughton, central by Simmons, or diffuse by Maslin. All of them were equivalent for generalized seizures. When the proposed classification of the epileptic seizures, which followed the classification of the epilepsies. That's interesting. If you paid attention to the dates that I gave you, they first tackled epilepsies and then seizures. Asmoni Marsan made again the same point that we need to have a better understanding of the pathophysiology to be accurate 100%, something that's still a problem, but we're making progress. So the physiopathogenesis of the epilepsies in 1969, and this is a wonderful monograph by Gastaut, Jasper, Bacot, and Waltreni, brought some interesting issues. And look at the title of this slide by Gastaut. And what he said is some considerations on the now discredited notion of idiopathic, genuine, or essential epilepsy. That's interesting. He argued that it's not a correct term. They tried to define a form of common generalized epilepsy that starts most often early in life, but not in any age. That's bilateral manifestations. They had provocative factors, no comorbidities, and a spike and wave discharge, and a good prognosis. And that stayed for us for a long time. The people in the room had very interesting comments. Lawrence de Haas argued that naming something which we do not fully fathom remains a precarious undertaking. Kugler indicated that the term had been a convenient way of grouping certain number of syndromes of undeterminate etiology. The confusion of genuine with genetic, with sterilization as a treatment. And testing may yield findings, and better not to speak of epilepsy of unknown origin. Now we speak of epilepsy of unknown origin with the test that we have. Lugaresi pointed out that some of the focal epilepsies may show benign outcomes. At that time, they thought that every focal seizure was a bad one, and some generalized ones have unfavorable outcomes with a Rolandic pseudofocality, and he discussed the natural history of the petit mal variant, the more difficult condition to treat. Sorel's classification is something in the same book that's worth describing, which he defined epilepsy as a symptom epilepsy, i.e. related to a tumor. Syndrome epilepsy were a group of several symptoms of various causes, but no etiology. Entity epilepsy, where he defined an electroclinical syndrome due to various etiologies and a well-defined evolution, and disease epilepsy as epileptic syndromes with a constant evolution that's different from category 2 due to a unique cause. So the next few years, the ILAE proposed the classifications. The EEG was obtained in the hospital settings, and the proposal came with a classification that we all know, which is shown again here. And then we have a burst of technology. We have new scientific advantages that allow us to see the seizures a little bit better, study them a little bit better. We have better computational abilities, maybe therapeutic options. And two interesting aspects of this came up. One is proposed by Giuliano Avancini and Peter Wolf and Pippo Capovilla on system epilepsies, which discuss a pathophysiological hypothesis of a group of networks that consistently may be affected by seizures. But then what really got me into this mess is the paper that I am a lot responsible for and introduced by Anne Berg, and you see the other people who are the culprits, which is the revised terminology and concepts for the organization of seizures and epilepsy, which created the new nuclear war. Thank you very much.
Thank you very much, Nico, for this very important speech. Very useful because he reminded us for the important steps to reach to the new classification. And we go to the next speaker, who is going to talk about the ILAE classification of seizure, Samir Zuberi from Scotland, very interested in neurogenetics.
Thank you, Thanos. So I'm going to be talking about the classification of seizures. When I took over the chairing of the Classification Commission in 2014, we decided that we would separate the classification of seizure types into one task force and the classification of epilepsies in another task force, one led by Bob Fisher and one led by Ingrid Scheffer. But there were many people who were on both task forces to maintain good communication. So, as you know, the 2017 classification of seizures and epilepsies was published online on 9th March 2017. The first official ILAE position papers on classification since 1989, and in fact the first position papers. And these are presented in 3 companion papers, and this is the work of many commissions, task forces, and individuals. And as you can see, it builds on the work of everyone since Hippocrates. So a few thousand years of work to reach where we are now. This is a quotation that one of my general pediatric colleagues sent me after he read the classification for the first time. I'm not an advocate for frequent changes in laws and constitutions, but laws and institutions must go hand in hand with the progress of the human mind as that becomes more developed, more enlightened as new discoveries are made, new truths discovered, and manners and opinions change. So it's not just that new truths are discovered, but culturally we change as well. And now our patients are very much, in many situations, more expert than the physician on their particular type of epilepsy. Our patients have access to information which they never had before. 10, 15 years ago, we had access to all the medical textbooks. We had the libraries. Now, any patient can go on and get any information about seizures, epilepsy, freely on the internet. So they very rapidly become educated. Whether they can put that into a context is another matter, but the knowledge is out there for everyone now. So the first position paper, which Ingrid will talk about, is the classification of the epilepsies, and I won't cover that in detail. What I'm going to be talking about is that the task force which Bob Fisher very ably led. Bob, as many of you know, is a very dynamic, organized individual, and he brought us all together, and he also took in not just the opinions of everyone on the task force, but extended that out to another group of individuals for the instruction manual. So the seizure type classification is presented in 2 papers. One which basically gives an overview of the classification, and another one which is a how-to-do-it manual. And that also includes a glossary of terms. It maps the old classification to the new classification. Now, when we were going through this process, these are 2 of the guiding principles. So we used Humpty Dumpty and Einstein to guide us. So when I choose a word, it means just what I choose it to mean, neither more or less. So we try and use simple language that hopefully not just us as physicians or people caring for epilepsy, people with epilepsy understand, but also individuals with epilepsy will find it more easy to understand. And we should try and make things simple as possible, but not simpler. So I think it's useful just to have a look at some of the 1989 definitions, because the reality is many people who care for people with epilepsy still don't know what many of these definitions are. As a person, as an individual training in epilepsy and neurology, as a registrar, senior registrar, I found it difficult to sometimes understand some of these concepts because of the ambiguity around them. So generalized, focal, and I'll go over those again, idiopathic, an epilepsy of predominantly genetic origin in which there is no gross neuroanatomical or neuropathological abnormality. Symptomatic, an epilepsy of an acquired or genetic cause associated with neuroanatomical or neuropathological abnormalities indicative of an underlying disease or condition. So idiopathic and symptomatic can both be genetic. Cryptogenic, an epilepsy of presumed symptomatic nature in which the cause has not been identified. So this also could be of a subtle neuroanatomical, neuropathological abnormality or a subtle genetic cause. So there's a lot of blurring there between these groups. So idiopathic does not, in the previous classifications, mean unknown, as many individuals think it means. So we have these two papers which put forward the new classification of seizure types. So a seizure is the transient occurrence of signs and or symptoms due to abnormal, excessive or synchronous neuronal activity in the brain. And a seizure type, as defined in this paper, is a useful grouping of seizure characteristics for purposes of clinical care, teaching, and research. And the key aspect of that is for clinical care. So for communication, a communication framework for clinical use. So these are artificial constructs that we've put together as physicians based on observations we make of features that people have during epileptic seizures. And this is the basic framework. So we have seizures which are of focal onset, generalized onset, or unknown onset. And we have kept this dualistic approach because it is so embedded within epilepsy practice, though many of us realize that, in terms of an etiology, this is an artificial distinction in many respects. We also then look, when we're talking about focal seizures, about whether the individual has their awareness impaired or retained. And that becomes a surrogate for impaired consciousness, responsiveness, awareness. As you know, there are many, many ways in which we can describe these features. So I think there's a paper in Epilepsy a few years ago describing multiple different types of consciousness that may be impaired in epileptic seizures. Now, we could list all of these in a classification, and in your own classifications you can do that. But I think in this framework we need to use as simple terms as possible. So we decided we would use aware and impaired awareness as a surrogate, and that replaces the complex partial and simple partial, because also it's more understandable to families and people with epilepsies. And then we have seizures with motor onset or non-motor onset, and that may go from focal to bilateral, tonic-clonic. So focal seizures are conceptualized as originating within networks limited to one hemisphere. They may be discretely localized or may be more widely distributed. So beginning in one hemisphere and involving a network within one hemisphere, but they may spread to the other hemisphere, so that it may become focal to bilateral. And those bilateral manifestations may be tonic, tonic-clonic, etc. Generalized seizures in the 1989 classification, the first clinical changes indicate initial involvement of both hemispheres. In 2017, they're conceptualized as originating at some point within and rapidly engaging bilaterally distributed networks. So they could begin somewhere focally, but they rapidly engage bilateral networks. So this is the more extended classification of seizure types. And this does not describe every single seizure type, but it describes the most important seizure types. And we hope that this will be a framework that will be in clinical textbooks for medical students, will be up in A&E departments, will be in your first seizure clinic on the wall, if people want to think about how they classify an individual's seizure type. And there are several new seizure types, and this was one of the reasons for updating the classification of seizure types. So, We've had this discussion about the of partial versus focal. We decided that we would move to focal rather than partial for seizure types. And we also know that certain seizure types can either be focal, generalized, or they may be of unknown onset. Unknown onset seizures, where you don't know whether they're focal or generalized onset, you can still classify them in this framework. And you use awareness as a classifier of focal seizures. The terms that had been proposed in previous classifications, such as dyscognitive, which many people did not like, simple partial, complex partial, psychic, secondary generalization, have come out of the 2017 classification. And there are seizure types that we recognize but had not been in previous classifications, and that was another reason. So automatisms, autonomic, behavior arrest, hyperkinetic, emotional, sensory, and focal to bilateral tonic-clonic are all seizure types, new seizure types. Atonic, clonic, epileptic spasms and myoclonic and tonic seizures can be either focal or generalized. Now, we often know that seizures, you can have a focal tonic seizure, you can have focal myoclonus, but these had not been listed in previous classifications. And also new generalized seizure types such as absences with eyelid myoclonia, myoclonic absence, and also myoclonic tonic-clonic have been included. We know that many people with juvenile myoclonic epilepsy will have a series of myoclonic seizures, then go into a tonic seizure, and then have a clonic seizure. And epileptic spasms, we know, can be focal or generalized. So they are in both groups as well. Now, the instruction manual has a lot of detail in it. So you need to, I think it's a very helpful document to read after you've read the first paper. So it goes through many of the common descriptors of behaviors during and after seizures. You know that almost any human behavior can be recapitulated during an epileptic seizure. And so there are long lists, Bob was really good at being careful to try and get as much detail as possible in these lists in the instruction manual of all the descriptors of focal seizures. And then there is a mapping of the old terms to the new terms. And if you look at this, you can't read this on here, but many of them are exactly the same. They're exactly the same. Many of the terms are exactly the same. So if you have an absence, you don't have to call it a generalized absence. You can just call it an absence. If you've got an absence which is atypical, you call it an atypical absence. So many of the names are exactly the same as in previous classifications. So this was published in March online, and then all of us on the classification commissions were anxious about how this would be received by our colleagues. And there have been a couple of papers that I've found commenting on this. So when I first saw the title of this, I thought, oh my goodness, are they complaining that there are too many seizure types in the new classification? But this is from a group who are on behalf of the SCORE consortium. So this is a letter to epilepsia, where this group have developed an EEG scoring system, and they're mapping that to the seizure types in the new classification. And what they wanted to do was to map and code each seizure type to the EEG correlate of that. So it can work in the scoring system. So I think this is a really positive paper, because it's showing how the new classification can be used to link into other classifications. Again, I found this paper by Tori Beggy in Nature Reviews Neurology, New Classification of Seizures in Epilepsy, and Advanced, ? So this made me a little bit nervous. And I couldn't access this on my university account, so I paid $5 to get 48 hours access through Nature. So I did that yesterday and read the paper. And actually, Professor Beggy said that he really liked the instruction manual for seizure types. He liked the multi-level flexibility, which allows you to classify, and Ingrid will talk about this based on available resources. The language is straightforward, so that's a positive thing. One of his anxieties as an epidemiologist, will the flexibility affect epidemiological studies? I think epidemiological studies are always affected by the resources available within a country in terms of classification. And should we develop an algorithm and codes for the degree of diagnostic workup in order to classify someone? So that may be a task for the future. He also said we haven't talked about syndrome classification enough and haven't given details on that. So the classification group now, the Nosology and Definitions Task Force, chaired by Elaine Wirrell and Paolo Tinoper, that is one of their tasks over the next 4 years, is to look at syndromes and what syndromes are now in the 21st century. And also, Professor Beggy said, well, we talk about comorbidities in the framework, but we don't describe exactly what they are. So he's wanting Ingrid to write an instruction manual for the classification. So that may be something that we do. So, but I think this, again, was a positive feedback. So we know that classification is evolving. It has been evolving since the time of Hippocrates. But many of the ideas that Hippocrates had are still in our current classification. It will never be perfect, but these classifications that the ILAE are developing for this purpose are principally for clinical work, but we hope that they will also help for research and other purposes. At the moment, we still do not have the underlying science to make a true biological classification, certainly of seizure types, but by bringing etiology into epilepsies, which Ingrid will talk about, we begin to bring science more into our classification. Words do matter, we've seen that, and it is a global task, and languages and cultures differ, and Satish will cover that area in his talk. So I hope that Humpty Dumpty and Einstein will be happy with what we've achieved to this point. So you should go back to the 3 companion papers in Epilepsia. Also, if you go onto the epilepsy, the ILAE website, all the papers are freely available on the ILAE website, and there are PowerPoint presentations prepared by Bob Fisher and Ingrid on the classification framework and the seizure types, which you can use for teaching, and also go to epilepsydiagnosis.org to look at seizure types. Thank you.
Thank you, Samir. The last slide about football is painful for an Italian. The way the 2017 classification is presented at this symposium follows the diagnostic algorithm. So we are faced with the event, a seizure. The first question is it epileptic or not? If the seizure is epileptic, the next question becomes what Samir has just addressed. How do we classify it? What type of seizure is it? And then the next question becomes, is it epilepsy? And if it is epilepsy, how do we classify that? So Ingrid is going to address that.
Thank you very much, Emilio. And I'd like to start by acknowledging the great vision of our current president, Dr. Perucca, and our previous ILAE president, Dr. Moshe, in making sure this has come to fruition, and then further in highlighting it in the Presidential Symposium as the key clinical tool that we use every day in our practice. So it's a long way from Australia to Barcelona, And that really mirrors the long journey that we've had in getting to the classification, the first final one since 1989, but building on a huge amount of work with the classification commissions in between. So many people say, I don't need to bother learning this, do I, yet? Because it's all a proposal. Are we there yet? Well, the answer is definitely yes. And this is about telling you about these papers that have come out and allowing you now to start the journey of using this nomenclature, terminology and framework in your daily practice, because it's really the start of a much more updated thinking around the epilepsies. So I'm going to start off from where Nico left off, and with our paper in 2010, which, as he said, started a nuclear war. And this was really a shock to all of us, because I guess we hadn't looked deeply enough into the 1960 literature where there were clear wars around classification. But it did start us on a journey which was defined by the ILAE and the new way to bring out a formal classification. And that was with a lot of engagement with the community, with discussion, with several different papers along the way. This was one that we published only online in November 2013, inviting commentary from around the world. And we had 128 people take the time to give us their very valuable thoughts, and they came from 43 different countries. So that was a wonderful global effort, and I thank you. We also had a lot of debate, and this was in every conference related to epilepsy I think I went to, and people are always passionate about this because we use it every day. But I just wanted to hark back to another US president, JFK, who said, "Change is the law of life, and those who look only to the past or present are certain to miss the future." And also just to spend a moment thinking about this work of Thomas Friedman, who highlights that this is a time of dizzying acceleration. We have an exponential increase in computing power, as shown by Moore's law. It's easier to be a maker of anything, such as 3D printing, but in many ways it's harder to be a leader. It's our role, we need to learn to be fast, where we're innovative and quick to adapt to changes in thinking, fueled by science in our field, fair to help those who are trying to adjust to the casualties of change, but also slow to shut out the noise and to access the deepest values. And this is very important in epilepsy as well when we think about the issue of stigma, which Dr. Jane will address after me, and we have to be very sensitive to these issues. So let's return to our purpose of the classification of the epilepsies. This is first and foremost for clinical work, for you and me in the clinic seeing our patients. It's probably the most important clinical tool we see with any patient we see. It's secondarily for drug trials, it's secondarily for research. So a key aim of this new classification is transparent language. We want to use words that mean what they say, and I know Samir has touched on this, but I just wanted to flesh this out a little bit more. The idea is that not just the doctors, but our patients and their families understand the words. It's much easier to teach medical students and health professionals, and I certainly see that in our junior medical team, that they understand the words more easily. And in 2017, attitudes have changed. We work with our patients rather than talking down to them. We don't have to hide behind a cloak of words that are unclear, like idiopathic. We can say unknown, we just don't know. And our patients still respect us because we can diagnose the seizure type, we can diagnose so many things, but we may not know all the answers. So just to highlight what I mean by words that don't mean what we say, and I think the most beloved to all of us would be the complex partial seizure. But complex in English does not mean altered awareness, it means complicated. Simple in English means straightforward or uncomplicated. It doesn't mean retained awareness. This is far from intuitive. So what we want now are words that mean what they say. So for focal seizures, we now say focal impaired awareness seizure. I promise you it rolls off the tongue just as quickly as complex partial seizure once you practice. and then also focal aware seizure for retained awareness. So this brings me to the new framework for the epilepsies, which begins with the seizure types, and then from the moment you see a patient, you need to think about etiology. And we've chosen 6 different subgroups. This is not complete, but we've selected those that impact on your choice of treatment and how you approach the patient. But we really wanted to say from the moment you see a patient, you should think about their etiology. We go from seizure type to epilepsy type. If you can, you diagnose the epilepsy syndrome, and all along the way, you're thinking about comorbidities. And these have become increasingly recognised. I think they were always there, but we were maybe not as aware of them as we should have been. And by that, I mean learning difficulties or intellectual disability, autism spectrum disorder, depression, cerebral palsy, a whole host of comorbidities that we need to be aware of from the moment that we see a patient. So let's walk through this framework and begin with seizure types. And this is where you're sure that the seizures are epileptic in origin. So we're not talking about distinguishing epileptic from non-epileptic seizures. That is taken as already established. Now, in some settings, that may be the maximum level of classification you can manage. That might be in a resource-poor setting, or it may be that you simply have too little information to make a higher level diagnosis. So a patient may have had one definite single event, such as a tonic-clonic seizure, but you may not be able to take it any further. You may have done an EEG and it may be negative, or you may not have access. So we begin with our seizure types, beginning now thinking in terms of focal onset and generalised onset, which we've always done, but the new group is the unknown onset. And as I've said from the beginning, you're thinking etiology. Sometimes people say to me, well, which one do I pick? So, for example, with focal cortical dysplasia, which etiology would you think about? Well, obviously structural, but increasingly we're aware now of genes that can cause focal cortical dysplasia, such as the mTOR pathway and the GATOR1 genes within the mTOR pathway, as just examples. But of course, tuberous sclerosis, many other disorders genes can be associated with focal cortical dysplasia. So you might say, well, which one do I use? Is this person got a structural etiology or a genetic etiology? And the way you use this is it's fine to use 2 or even 3 etiologies, but you might focus on the one that is more important for your patient. So if you're in an epilepsy surgery program, obviously the structural etiology is going to be important. If you're talking to a family about a recurrence risk and reproductive counselling, then the genetic etiology is more important. What about glucose transporter 1 deficiency? That is clearly genetic, but it's also clearly metabolic. And there are many etiologies that you'll know that will fit into more than one group. So moving from seizure types now to epilepsy types, this might be the maximum level of diagnosis you can make if the patient doesn't fit into a clear epilepsy syndrome, or they may not be able to, or you may not be able to make a diagnosis of etiology. There are many examples where patients fit into this sort of group. Temporal lobe epilepsy is not really a syndrome as such. If you see a 5-year-old child, they have generalised tonic-clonic seizures, they have generalised spike wave on their EEG. That doesn't fit into a well-recognised syndrome. You might see a 20-year-old adult with focal impaired awareness seizures and true absence seizures, and they have both, and they may fit into the combined group. Or you may not be able to tell if a tonic-clonic seizure, and the patient has many, has a focal basis or a generalised basis. The new group is this combined generalised and focal group. And why did we bring that out? Well, I think it's because we all see patients that have both generalised and focal discharges and generalised and focal seizure types. And nice, neat examples of this are Dravet syndrome and Lennox-Gastaut syndrome, but there are a host of the developmental and epileptic encephalopathies that have this, and there are other syndromes that are not severe that may have it as well. So sometimes people say, well, what do I do if my patient has a multifocal epilepsy? What do I do if they have a hemispheric epilepsy? Well, they both clearly fit into the focal basket. So then we move on to the last part, which is the epilepsy syndrome. And I'm a major lover of epilepsy syndromes and try to place every patient I see into an epilepsy syndrome. Probably the most favourite of us all are the old group known as the idiopathic generalised epilepsies. And these encompass 4 different well-recognised epilepsy syndromes: childhood absence epilepsy, juvenile absence epilepsy, juvenile myoclonic epilepsy, and generalised tonic-clonic seizures alone. So this term idiopathic has been touched on already by both previous speakers, and it comes from the Greek word idios, meaning self, own, or personal. In the 1989 classification, it was used to mean no underlying cause other than a possible hereditary predisposition. And the wonderful Charlotte Drave came up to me a few years ago and said what we meant here was genetic when we were putting this together. So in the 89 classification of the epilepsies, they separated those with a known etiology into symptomatic and those with an unknown etiology into idiopathic. But these words are not using transparent language. So one of the causes of confusion about genetic versus idiopathic is that genetic does not mean inherited, and many of us think that it does, but actually it does not. And we now know that there's an increasing recognition of new mutations in all of us, and these have been shown to cause mild epilepsies, even mild GLUT1 epilepsies, and severe epilepsies, such as the developmental and epileptic encephalopathies that I'll talk about a bit later. But there is a very critical issue around the word genetic, which is that it carries a stigma in some cultures. And I think we have to consider very carefully the words we use to get this concept across. And I know my Japanese colleagues have told me that Japanese has several different words for genetic, and they're being very cautious to choose the one that will have the least stigma. It's also important that we educate the community and clinicians regarding causes of epilepsy, and we don't hide behind a veil but help people understand what the new science is telling us. A genetic diagnosis already guides management, and a good example of this is GLUT1 deficiency, glucose transporter 1 deficiency, where the ketogenic diet is the treatment of first choice. But we do need to use these words and frame them in the right way. The other critical issue, that genetic testing does not mean that you need to know the gene. In fact, mostly, none of us know the gene involved. And this is partly because the genes aren't discovered, but partly because we cannot access molecular genetic testing for the vast majority or any of our patients in some cases. So how can you say it's genetic? Well, this is based on beautiful clinical research, such as twin and family studies. And here you see 2 slides put together by Sam Berkovic using Lennox's work from the 40s and 50s, where you see beautiful identical twins who have identical EEG abnormalities with juvenile myoclonic epilepsy. And here you see some very 50s-looking twins with, who have childhood absence epilepsy with 3 Hertz generalised spike wave. So there's our framework as it stands. And in this group of the idiopathic generalised epilepsies, we have now decided you can use the term idiopathic generalised epilepsies if you wish for those 4 syndromes, or if you're comfortable, you can use the term genetic generalised epilepsy to leave there a little bit of wriggle room for people to use whichever they see fit. So, Samir mentioned epilepsy syndromes. What are the approved ILAE epilepsy syndromes? I hope you've got your thinking hats on here, because there are none. So we have currently no approved ILAE syndromes, and the new classification group may take this forward. What I do recommend is that you go and look at this website. If you haven't done that, then you should be doing this at some stage today while you're on the web, and have a look at this phenomenal website put together by Kate Riney and a team, where you can look up all different types of seizures, EEGs, syndromes. Now, this is not contentious. This is all established, well established, and is a fantastic teaching tool for your students. So this is the general front page. You can then go into a seizure type, and here you see the typical absence seizure. That will tell you what you need to look for, but also red flags. What should you think about that this may not be an absence seizure? And then it's really cool. You can get on and look at 10 different absence seizures. Now, you do have to register for that. It takes 1 minute. And then you can use this to teach your students about the different features of absence seizures, other syndromes, and other seizure types. I also wanted to point out there's a very good page on epilepsy imitators, because of course we're often teaching our residents and registrars about what is not epilepsy as well. So what other changes do we have? Well, the term benign has been in the epilepsies for many years, but with the research that's come out, it's shown that even these syndromes that we think of as benign, and they are much, much milder than the severe end with the developmental and epileptic encephalopathies, even these mild ones are not so benign. The literature on childhood absence epilepsy shows a significant psychosocial impact with poorer educational outcomes and increased risks of teen pregnancy. Even if you think of one of the mildest epilepsies, benign epilepsy with centrotemporal spikes, you see that these children have learning concerns, and there is a little bit of debate in the literature whether their neuropsychological deficits resolve or actually do not resolve. So these are not benign disorders. So we've chosen to replace these terms, this term of benign, with two terms because they have different meanings that are important: self-limited and pharmacoresponsive. So it does help if you can tell a family of a 10-year-old boy with benign epilepsy with centrotemporal spike, you are going to grow out of this. It is a self-limited epilepsy, and it's likely you'll be controlled with the first anti-epileptic medicine. And we definitely no longer want to use the terms malignant or catastrophic. They should be gone. So I wanted to move on then to the term epileptic encephalopathy. And this was first raised in the 2000s, in Pete Engel's time, as a very important concept where this epileptic activity, and I've shown it to you at the back here, a slow spike wave EEG, this epileptic activity itself contributes to cognitive and behavioural impairments beyond that expected from the underlying pathology alone, for example, a cortical malformation. So it's a far more severe sort of epilepsy that's impacted on the etiology. And in this most recent paper, we've introduced a slightly more complicated concept of a developmental and epileptic encephalopathy. And this is really in recognition that many of these disorders, their cause causes both a developmental consequence as well as an epileptic encephalopathy. So you need to judge with your patient, do they have both a developmental and epileptic encephalopathy? Do they have just the epileptic encephalopathy? Or maybe they have a developmental encephalopathy as an intellectual disability without an epileptic encephalopathy, and I think we need to learn to separate these apart. So the thinking about this extra word of developmental and or, depending on the patient, epileptic encephalopathy has really come about because as we've discovered new causes for these disorders, we've noted that many of them have an independent effect on development as well as the epileptic encephalopathy. So here you see a little boy with a KCNQ2 encephalopathy. He's 4 years old. His seizures stopped when he was 2, and he has a normal, well, a slow EEG, but no epileptiform activity. So now he no longer has an epileptic encephalopathy, although he had one in the infantile period. So we think now that many of the genes that we see have both effects, and one has to recognise that some is the primary gene causing this, and some of it is the epileptic encephalopathy. And a good example of this is SCN1A, which of course we know is the gene for Dravet syndrome, where there are children just with autism spectrum disorder and no epilepsy that have mutations of SCN1A, although of course the majority have a developmental and epileptic encephalopathy. Now, Professor Rima Nabush yesterday spoke with me, and she said that people are now paying a lot of attention to the developmental component, but not really recognising how critical this epileptic encephalopathy concept is, and she's going to expand upon that in the major symposium on Tuesday. And it's important to recognise that this epileptic encephalopathy comprises often seizures and or frequent epileptiform activity. It's usually both. And these together result in developmental slowing or regression. Now, this concept of an epileptic encephalopathy can occur at any age. So why does it matter? Well, it matters because it may be treatable. One example is where you have a structural basis, and here you see a tuberous sclerosis image, and it may be that with epilepsy surgery and removing the most active tuber or tubers causing the seizures, you can resolve the epileptic encephalopathy, and the child's developmental progress is dramatically improved. They may be left with focal epilepsy, but they don't have this secondary epileptic encephalopathy. This also holds true for the genetics, and here you see SCN1A, which we know is mutated in about 90% of patients with Dravet syndrome. And we know that with those patients with this cause, if you use the wrong drug, carbamazepine, they can do much worse. You can actually make their epileptic encephalopathy worse. If you then change them to the right drugs, be they topiramate, stiripentol, or valproate, you can actually improve cognition. So this issue about an epileptic encephalopathy is absolutely critical and should be foremost in your mind when you're seeing patients with these disorders, in case there's something that you can fix. So just to emphasise again that both of the developmental encephalopathies and epileptic encephalopathies are different but related concepts. And I think with time we're going to move to this concept of a gene encephalopathy, and we'll have an understanding if it's epileptic and developmental or just one. The other issue I wanted to highlight is that many of these disorders are now associated with movement disorders such as the stereotypy in the boy on the left, the cerebellar features in the girl in the middle, and the hyperkinetic choreoorthotic movements on the child on the right. And these are all children that I see with different genetic, developmental and epileptic encephalopathies. And within the developmental and epileptic encephalopathies, we have a whole range of very well-recognised syndromes, if you like, the more common ones, and then much rarer ones, many of these being generalised and or focal. We have ones that are just focal. But as well as that, we see many patients where they don't fit clearly into one of these known syndromes, but do have this process of a developmental and epileptic encephalopathy going on, and the epileptic encephalopathy is important because it may be remediable. The last term I wanted to touch on is a beloved term to many called symptomatic generalised epilepsies. But this term has really come to mean two different groups of disorders, the developmental and or epileptic encephalopathies, but also the static encephalopathies. And by that I mean your child or adult with intellectual disability who may have epilepsy as well, but they do not have this epileptic encephalopathy process. And it's important that we now dissect this out because our treatments may differ. So in conclusion, with the new ILAE classification of the epilepsies, we've simplified the framework. We think etiology, etiology, etiology at all stages and every time you see your patient. We've broadened the epileptic encephalopathy term to include developmental and epileptic encephalopathy. We've got rid of benign and brought in self-limited and pharmacoresponsive. We've using the term genetic generalised epilepsies, which encompasses those 4 well-known syndromes, but many other patients that don't fit clearly into those syndromes, and we've said you can use the idiopathic generalised epilepsy term where you wish. And the symptomatic generalized epilepsy term has gone and is broken down into both the developmental and epileptic encephalopathies, and then a static encephalopathy with epilepsy. We hope that this will make a major difference to clinical care and practice. It will change your approach to diagnosis in the clinic, and you'll use it with your patients, and it will help you with management. And it will update, and we have updated the terminology to reflect current thinking based on scientific advances. And I'd like to finish by thanking the wonderful classification task force who helped bring this to fruition, together with the help of the commissions over many years. Thank you very much.
Thank you, Ingrid. For those of you who are keeping track on your watch, we are not ahead of time. We will leave some time at the end of the symposium for discussion, so if you have any questions, just keep them and you'll have the opportunity at the end. The next speaker, Satish Jain, was not actually originally a member of the task force. In the process that was been alluded to before, of involvement of the community through the ILAE website, through the various drafts of the document that were presented, Satish made a lot of very comprehensive comments about cultural sensitivities that could be affected by terminology used in the document. So we co-opted him, and his contribution has been extremely valuable. And he's going to address, in fact, how we apply the classification, taking cultural context into account. Satish, your turn.
Respected chairpersons, learned speakers, fellow delegates, and friends. I wish to thank the organizers of the symposium for having invited me not only to the task force, but also now to present my views on a topic that is not often discussed. This, ladies and gentlemen, is the traditional way we address an audience in our culture. Hi, folks. My talk is going to be totally different. There's nothing fancy. Nothing to record on your fancy cell phones and notebooks. So I would like to say, as the captains say in the flight, sit back, relax, and enjoy the talk. Well, some of you must be wondering, and Pete Engel, in fact, noticed that I'm not wearing a formal Western dress. Now, the reason for this is that I was trying to find a representative national dress from India. And India being so different in culture, in traditions, so big, it's just like Europe. So it was very difficult for me to find a national dress. So I just chose this jacket, which is a symbolic representation of the dress that most people would wear during a struggle for independence. It's not only this in India. If you come to the Southeast Asian region, you see the diversity in culture and dressing. So everything keeps on changing from one small part of the country to another. So there could be so many different varieties of dresses worn by women in only Southeast Asia. And it's not only the dress. Our part of the world is different. We have different festivals. All the faiths are represented in our part of the world. We have different customs. And of course, besides the dresses, we have different facts and history of our own culture. Now, the cultural aspects of Asia, the basically thing is it's so diverse. It's very difficult to put together the different cultural aspects in one small talk or one paper. We have different kinds of cultural heritages of many nationalities, societies, and ethnic groups that coexist in this part of the world. The continent is more commonly divided into more natural, geographic, and cultural subregions. Unfortunately, culturally, there has been little unity or common history for many of the cultures and people of Asia. Very important fact is that the Eastern philosophy and religion, these two things have always played a very major role. Now, the most complex part of Asian culture is the relationship between the traditional cultures and values of our part of the world and the Western world. Certain cultural practices and beliefs could be so different that they may appeal offending to people who are not used to that part of the world. One of the practices in our part of the world is touching the feet of elders. Now, this is not only a cultural ritual to seek blessings. There's been a lot of studies on this, the scientific aspects of seeking blessings by touching the feet. If you Google it, you will find many references. Now, this to someone else may appeal offending. This may even be taken as part of slavery. But this is our culture, and this is where it's respected, you respect the elders. The culture is so old that Nico Moshe was referring to the mention of epilepsy and different types and different classifications over the years. In one of the Asian Ocean conferences, I reviewed the entire Indian Ayurvedic literature and I presented a talk. And in the period ranging from 1000 to 2000 BC, we have what is known as Charak Samhita. There is clear mention of epilepsy as a disorder of the brain. There is clear mention of a classification of epilepsies. There is clear mention of role of hereditary factors in epilepsies. And also, there is a differentiation between genuine seizures and pseudo-seizures. So, these things have run parallel, and we have also been, knowing about all these things. Now, this slide I took from the ILAE website. Now, there are approximately 114 chapters around the world, and you imagine where different people with epilepsy live today. It's such a vast world that we have to take in account and respect all beliefs and cultures. Now, most of the times, as I said, transcultural aspects of epilepsy, these are usually forgotten. There was an editorial by Leigh Sanders a long time back in Epilepsia, where he had mentioned that the reasons of the failure of treatment in different parts of the world, they are complex and they involve non-pharmacological aspects such as the cultural attitudes to epilepsy. Many people believe that epilepsy should not be treated by drugs, and there are different other ways to treat it, still prevalent, unfortunate. And in his editorial, he further said that one of the issues that the global campaign will address, that the cultural issues will be the forefront of this campaign and the transcultural aspects. Now, this was way back in 2003. Now, still very often, unfortunately, the cultural issues are not taken care of. Now, epilepsy is a global health problem. All of you are aware, I don't need to introduce this. It's estimated that there are at least 50 to 60 million people with epilepsy today, and about 40 to 50 million people live in developing countries, and that's where I come from. Almost 30 million people with epilepsy, they live in the Asia-Oceania region. That's half of the world's epilepsy burden. Now, there was an article in Neurology Asia in 2007, and it said that all major regions and cultural beliefs are heavily represented in Asian Oceanian region. And the two countries with the longest history and largest population, that is China and India, both are part of this region. And they account for 40% of the global population and almost 40% of the global epilepsy burden. Now, the difference in the traditional beliefs about epilepsy in this region are quite distinct. And it is believed that we should seriously look into even the research priorities in studying the psychosocial and cultural issues of epilepsy. So I'm glad that at least this topic is there today as part of this very prestigious symposium. The late Hanneke de Boer, a very dear friend, she wrote that the impact of epilepsy rests not only on the individual patient, but also on the family and indirectly on the entire community. And the social exclusion as a result of negative attitudes of others towards epilepsy and the stigma as children with epilepsy may be banned from school, adults may be barred from marriage, and employment is often denied even when seizures would not render the work unsuitable or unsafe. Now, all these factors are there, whether you like it or not, these are there, they exist. And all these add to the stigma of epilepsy. In the developing world and also in the developed nations, those having epilepsy themselves or having someone in the family with epilepsy, they experience stigma and social exclusion. The stigma and discrimination is often related to their school, higher education, leisure activities, career, job opportunities, marriage, having children, and even health insurance. Till recently, I was not aware that in India, if you have epilepsy, you declare it, you will never get a health insurance. For a person with epilepsy, especially in our part of the world, marriage is the biggest challenge in developing countries, and more so in women as compared to men. So we were so concerned that we decided to bring out a little booklet to help people who have epilepsy and their family members. This is, we accumulated all the laws in regards to epilepsy in India, and we made an expert group in the Indian Epilepsy Association and Indian Epilepsy Society, and with help of legal experts, we came out of this book, and this book included laws in relation to education, leisure activities, driving, career, job opportunities, discrimination, life and health insurance, disability, and income tax rebate. This was to help people to overcome the stigma, overcome their problems. And this book was released by the now President of India in a conference we had in Patna earlier this year in February. Now coming to the talk proper. Now I have a disclaimer that my presentation is in no way aimed to dilute or deny the role of genetic factors in the causation of various types of epilepsies. This may please be not taken so. Everyone in the developing countries is equally aware that genetic factors are important and genetic factors do cause epilepsies. My talk is only an attempt to put across the dilemma of an average clinician who is fully aware that the genetic factors do play a role in the etiology of epilepsies, but then he has to classify a patient's epilepsy as being of genetic origin based on hard scientific data. But in that exercise, he may end up accentuating the already existing stigma due to epilepsy, considering mainly the local cultural beliefs and practices. And the cultural beliefs can be so important, as Nico Moshe started his talk with the word war. I'm sure the audience here, especially those from Europe, are fully aware of the catastrophes that have happened in different wars based on cultural beliefs and some communities and some other people who are specially targeted. This can happen anytime, anywhere. So the arguments that I'm going to present, now these mainly revolve around the use of the 2017 classification of epilepsies in populations with vastly different cultural beliefs and practices in parts of the world where most of the people live today. And here, I would like to apologize beforehand, seek apology from people who may feel offended, mainly because our cultural beliefs and practices are different. They are totally different. You people may not be able to understand that, those who are alien to that culture. And in India, during this period, there's a tradition of seeking apology from everyone for the faults that you might have committed knowingly or unknowingly. So in my presentation, if I have offended anyone, I seek apologies beforehand, following our culture. And this is what the paper is. I'm sure people before me have already alluded to this, and this was discussed in detail, and Ingrid very nicely brought up as to how we as a task force came about with this new proposal. Now, the main problem starts with the idiopathic generalized epilepsies. Now, these 4 common human epilepsies, which are classified as IGEs, and the term idiopathic was not recommended in the 2010 proposal, principally for the aim to move to more transparent and more clear language. Now, in the 2017 classification, this has been restricted to only 4 specified syndromes, and as Ingrid showed, these slides are borrowed from her. These are the 4 syndromes, common syndromes, everyone knows about it. Now, in 1989 classification, fortunately, we had that 89 International Epilepsy Congress in New Delhi, and I was a young neurologist who was involved with the organization of the conference, and since then, I'm proud to say that I have been continuously associated with different developments, and it was a real privilege to be member of the task force of 2017 classification. Now, in 89, idiopathic referred to an epilepsy of predominantly genetic origin where there's no gross neuroanatomical neuropathological abnormality. Now, the present task force in 2017, while retaining the term IGE for a variety of reasons, it was clarified in the discussion that it is not necessarily synonymous with genetic epilepsies of generalized epilepsies of genetic etiology. Now, this term was confined only to 4 syndromes, and it was also clarified that they may not have necessarily a genetic etiology. The etiology could be different or unknown in certain patients with the same syndromes. The task force recommended the term IGE that could be acceptable only the 4 syndromes as I mentioned, but in individual cases, the term genetic generalized epilepsy may be used where the clinician is comfortable and has sufficient evidence for invoking a genetic etiology. Now, this is where the problem starts. We know that it's genetic. It's a hard fact it is genetic, but this adds to the stigma. And that's where the cultural differences are very important. Now, in most patients with IGEs, use of the term genetic generalized epilepsy may best be avoided, considering the context and implication. This is clarified by the task force. The task force, like Ingrid mentioned, that word genetic may sometimes be wrongly interpreted as synonymous with inherited. It is not so. But this will happen once the terms are used. This will go to the periphery and things become totally different. Now, any use of the term genetic in routine in common epilepsies will certainly carry the risk of multiplying the evil effects of the stigma due to this often labeled evil disease many times over. And as I said, stigma is maximum in regards to education, career opportunities, discrimination in employment, marriage, and insurance. Now, we saw slides about Newton, Humpty Dumpty, and all that. Now, I'm presenting our part of the world. Now, this man, Chanakya, the biggest philosopher and administration the world probably has ever seen. Now, he has his list of do's and don'ts. And some of the things that he mentions are just like living funeral for a man, and it is true even today. Please focus on the last line. That is, a daughter who's not married or divorced or widowed is as good as a living funeral for a man. Now, this may be totally different viewpoint in the Western world, but in our part of the world, this is important, and even today, it is so. So, the use of word genetic in known genetic disorders. Now, this is another paradox here. You can review any exhaustive list of known proved genetic disorders where we know the chromosome, where we know the trinucleotide repeat abnormality, where we know the mutation. I am yet to find even a single disease where the name of the disease has been prefixed with genetic. For example, Dravet syndrome, or any other syndrome you take, hereditary ataxias, spinocerebellar ataxia, the word heredity has been removed. It's called spinocerebellar ataxias, SCAs. So the word genetic is not used. Perhaps people were aware that it's going to add to the stigma. It's not that they are not genetic. They are genetic, truly genetic, yes. But using the word adds the stigma. So the potential stigma when you apply this classification basically is from genetic generalized epilepsies, although the task force clearly specifies that it may be used only in specific cases where the clinician is comfortable. but still there would be a stigma in many cultures. In future, as we understand more about the genetic mechanisms that may be involved in different other epilepsies, more knowledge will be there. I'm sure the situation may be clarified further, or it may get even more confused. Who knows where we are going to lead to? And similarly, we do anticipate that with the public education, people in developing countries especially are going to understand and accept more and more that genetic factors do play a role, and hopefully with decent public education programs, the stigma may be reduced. So, when you apply a label of genetic to a particular patient's diagnosis, do remember to keep in mind the perspective of the patient and the family members also. This is something that is ignored very often. Usage of the term genetic generalized epilepsy without sufficient and definitive evidence can certainly have legal implications because the law understands medicine and science in a different way. Merely saying a family history is positive or something is there in twins does not seek the approval of the lawmakers, and there it's not proved genetic. So besides the stigma that it might add, it will have some legal implications someday or the other. So when you are in a situation like this, you know that the syndrome is genetic, you know patient's epilepsy is genetic, but still you may not want to call it a genetic, so how do you seek a balance? This is a dilemma which everyone is going to face. So since this is not based on science, this is a moral issue, this is a cultural issue, so I had to go back and dig into ancient Hindu philosophy. And I'm referring to quote from the Manusmriti. Now for those who do not know, Manusmriti is an ancient legal text of Hinduism. Now this was written somewhere around 2 BC to 2 AD area. Now this is one of the first Sanskrit texts that was translated during the British rule of India in 1794 by Sir William Jones and used to formulate the Hindu law of the colonial government. This is such an important document. Now it says, one of the shlok there, Satyam bruyat priyam bruyat na bruyat satyam apriyam priyam cha nantram bruyat isha dharma sanatam. I'll just translate very simply that one should speak the truth which is agreeable and not speak the truth that is disagreeable, which can harm anyone, which can be disputed. Of course, one should never speak an untruth which is pleasing. That is the basic of dharma. Now, dharma is something that cannot be translated into English. There's no single word that I could find after extensive review. But the shloka emphasized the niti, that is the right path, that is the morality, the cultural issue as to what you should be doing right in that particular situation versus what may be correct, what may be right. There's difference of doing, in between doing something that is correct and that is right. If you do something correct, that is niti. If you do something right for that situation, that is dharma. In very simple words, I would like to put it that way. So dharma has Sanskrit root in dhri, which means that which upholds, or that without which nothing can be stand, or that which maintains the stability and harmony of the universe. Now this is all philosophy. This cannot be explained by science. Dharma encompasses the natural, innate behavior of things, duty, law, ethics, virtue, etc. It provides the principles of the harmonious fulfillment of all aspects of life, and that is the basic essence of all doctors, all the medicine that we practice. That is our fundamental goal, that we want to have a harmonious fulfillment of all aspects of life without pain. Dharma tells us to follow our conscience and do what is right for this situation. So this slide again I borrowed from Ingrid, and when you classify the epilepsies, I personally feel, and this is where the IBE and the ILAE have to work together, and ultimately, like Ingrid also very clearly mentioned, that when considering the etiology, one should use words that allow flexibility, taking into account the cultural context. This is very important, and this is the core of my presentation, and I think this is the true dharma. And that's why all these Hindu philosophy slides were there in my presentation, which might have offended some people. Now, reducing the stigma, what are the lessons we have learned in India or in Asia from the Western culture? First, the use of the word epileptic is now discouraged. This is a very big step. The effort was there right from the beginning to reduce the stigma. The word handicapped has been replaced by physically challenged, and physically challenged has been replaced by differentially abled. And our government went to the extent that our Prime Minister, on 3rd December 2015, he for the first time suggested that instead of calling disabled, in Hindi it's called Vikalang, that means they are handicapped, you call them Divyang, because he feels that they have divine body. If they are disabled somewhere, they have gained something else. So our whole ministry today is called Ministry of Minorities and Disabilities, that is today called Divyanjan Ministry. So they are all called divine people now. And persons with disability rights has been renewed last year, and the new act is coming. So we should all aim to reduce the stigma, not only treating patients, not only making a fancy diagnosis, but please keep stigma in mind. And here, the IB has to play a major role along with the ILAE. The IB must take up the responsibility of educating people and reducing the stigma. And the ILAE has to pitch in about educating about the genetic etiology, about the possible hereditary factors. Everything is there, it's a fact, but then how to understand and how to accept them. And of course, as Ingrid said, this is the small group we had. We had wonderful discussions, arguments, we did not agree with each other, but ultimately, and in the last 10 days, we have had some wonderful exchanges between few of us, and due to those exchanges, I got the support, and it was clear in my mind as to how I should put across my viewpoint in a very positive way. That idea is not to reduce the effect of genetics, it's not to dilute that, but basic aim is, because of the cultural issues, we should try to reduce the stigma in whatever way possible. Thank you very much, ladies and gentlemen.
Well, thank you, Satish, for bringing up those cultural sensitivities which are important. And in fact, that is what has led mainly the ILE to retain the possibility to use the term idiopathic generalized epilepsies exactly to take that into account. I also like your last slide, which goes back to some of the comments that were made before, that culture is not something which is fixed. Culture is something which changes with time as knowledge and education improve. And that is where the main role of IBE should be, and I fully sympathize with that. So maybe pass on the microphone to Thanos, who will now coordinate. If you have any questions, we can take a few.
Well, to thank all of the speakers for these excellent speeches, and the session now is open to questions, please. Yes?
Hello, thank you for the excellent talks. I am Arturo Galde from Spain. Just a comment for Dr. Moshe. It's true that the French managed to influence a couple of terms in epilepsy, but I have to say that the Greek haven't done bad with the terminology in all medical terms. Apart from this, just a couple of quick questions. How can we tackle the problems of translation for the terminology? Just giving quite a weird example. The term wicked spikes has been translated to Spanish sometimes as something similar to wicked spikes, because somebody did something wrong there. And so how can we tackle these problems? And the second question is, where are the negative myoclonic seizures? How can we fit that in? Thank you very much.
The first comment that you addressed, since I am unable to speak Greek, I would not understand how to use a Greek term. However, I do speak Greek. And I would like to point out to you one of my favorite diseases. Do you know amyotrophic lateral sclerosis? Is that correct? What you're saying is no muscle atrophy, sclerosis. No muscle. You don't talk about myoatrophy. So a lot of the words that they have come into the English literature is from translation of terms that people put together using Latin and Greek origin. So that makes the difference. And for some of us who speak Greek, sometimes we get very annoyed. The reason I mentioned absences and petit mal, as the French have dominated that, because I still say absence and I still say petit mal or grand mal. I avoid the grand mal, but absence is there. Now, the major issue about translation is that's where we need all of you. We need every country to come up with the terms on how you explain wicked. When I teach my residents, I talk wicked, not wicked, and I made the emphasis, but we need you to tell us how we can use the terminology in Spanish. We need somebody who can tell us how we can use it in Indian or Chinese or something like this, so we can understand it and we can follow through.
Okay, thank you.
Yeah, the negative mic, that was an issue that was actually raised in the letter from the SCORE group that I put up. And I think Bob Fisher has sent a reply, which is in Epilepsia, to that specific, so you can read the reply, which gives more of an explanation. But I think it was in the basic framework picture, we didn't want to put every single subtype of epileptic seizures and not all the more common types. So it's regarded as a subtype of myoclonus, but it's a point well taken that it's not in that list. Yeah.
Okay, thank you very much.
Okay, please.
Manuel Campos from Chile. Ingrid said in paper, it's very clear, it's a classification of epilepsies, plural, and epilepsy syndromes, plural. But in our classification, in ILAE website, said epilepsy is one disease of the brain. One disease of the brain or many syndromes? Please, when I performed the class in the university, the people said, what is one disease or syndrome? For me, it's many types of different syndromes, but the website said it's one disease of the brain. Where is?
That's a great question, and I think that the issue about epilepsy being a disease is something that the ILAE brought out in 2014, I think, wasn't it? Where they brought that word, moving us from disorder or condition to disease, really in recognition that this is a very severe condition, and calling it a disorder made it a little bit softer, really, whereas a disease means we are dealing with a disease, this is serious, let's get on with it. I also think that we are now coming to specific sub-diseases or etiologies that are diseases like STX-BP1 encephalopathy, just as one of many examples. So I think epilepsy is a group of diseases, but when you're talking about it broadly in a teaching, in a political context or a community context, I think it's good to use epilepsy as a disease, and I do now use that word, but I also talk about the specific etiological diseases, if you like, under that. And I think now a patient walks in and I think they've got CDKL5 encephalopathy, and that's how I think about that patient, which is why we've brought in the emphasis on etiology. So both ways.
Thank you, Ingrid.
Thank you very much.
Yes.
Hold on a minute. We didn't answer your question in reality. The issue, you responded to the disorder versus disease. His question is, should be using epilepsy versus epilepsies. And this has been going on for 140 years, and we all know we should be using the word epilepsies because there are many conditions. However, there's some technical issue. For example, this is the 32 International Epilepsy Congress, not Epilepsies Congress. We have to change a lot of things to go into that. So talk to your people about epilepsies, but let us keep the term epilepsy for the what we show in IBE, International Bureau for Epilepsy, not epilepsies. But we're all talking about epilepsies, and it's a disease, as Ingrid said.
Yes, thank you very much.
Okay.
Back there, please.
Yes. You know, with using the, can I ask Dr. Ingrid, and probably, using the new classification of focal epilepsy with impairment of awareness, don't you think sometimes keeping complex partial may be more flexible in a way Like impairment of awareness, for example, a patient who becomes aphasic during a seizure, and we don't know whether it's a motor or sensory aphasia. Is he truly have impairment of awareness or not? The reason I'm asking, when you describe seizures in a body of epilepsy or video EEG report, it may contradict the final diagnosis, the localization. Is it lateral temporal lobe epilepsy, for example? Is it mesial temporal lobe? My second question is, with the new classifications, do you think what's the time frame to change the ICD coding?
Okay. I think if you look in the classification, there are many descriptors. So you can describe an individual to a very significant degree of complexity, if that's what you're talking about, complex, in terms of complexity of an individual. So there are many, many descriptors, whether it's aphasia or other emotional or other clinical features. So you can describe an individual in many ways. So if you don't think the principal feature is retained awareness, you don't have to, or impaired awareness, you don't have to use that term. The second term was about ICD. Now, ICD, I think the ILAE and IBE should be leading ICD. So ICD should be following on from the concepts that are developed by the epilepsy specialists and by people with epilepsy. So, and ICD classifications historically fall a long, long way behind our current thinking. I mean, I think in the States now, they're just going on to ICD-10, whereas, they're going into ICD-11. So I think ICD is important for billing and other things, but we're talking about our patients and clinical practice. So we need to concentrate on our ILE classifications.
One more comment. The ICD-11 is a lot of information in there is based on the 2010 proposal because we were able to communicate with WHO to include those things. However, it's changed a little bit and the WHO is behind the days. So in the next revision, you will see the additional categories of etiologies that it's really the main difference.
Thank you.
Okay, please.
From Washington, D.C. I had a question for Dr. Moshe and for anyone else from the panel who wanted to comment. If you came across the semiological classification as was proposed by Dr. Hans Hutter, where the primary arm is the semiology and the secondary is the epileptic zone. I was trained by him, so that's kind of the approach we use, but I find in practice when I first see a patient, the semiology is perhaps all we have, and then as you do more diagnostic workup, it gets more refined. So what are your comments about, shifting the primary R to more semiology focused?
We are all looking at the symptomatology and the semiology, and Hans has described a very detailed approach. Sometimes that's very difficult to do into the emergency room. And I would like you not to be in your hospital in Washington, D.C., but perhaps you can be somewhere in a surrounding where you have a nurse or even a health professional trying to identify what the symptoms are. We need to talk to these people. Now, as we go along and we become epileptologists, you can add all the layers of complexity that we are all using. However, the major point that Ingrid made was, can you say it again? Etiology. Etiology. It is not whether my little finger moved first or my thumb moved first, but what caused this. And that's what we're trying to introduce. And we really appreciate all the contributions that Hans has made, which are amazing in understanding where the pathophysiology of the seizures may be, together with others.
Thank you.
Thank you very much. I think the next is you and then Alex.
Thank you very much. Talking back to etiology, I have, and I don't know if it's prudent to consider that maybe all genetic etiology could be considered as structural etiology. What do I mean with this? Because we first saw in imaging the structural abnormality. Many times when we didn't see in imaging, we could see at anatomical pathological level that there was a structural abnormality that we didn't see in the imaging. And if we go further more from macro to micro scale, we could go to nanoscale and maybe even GLUT1 or SCN1A mutations reveal an abnormality and structural in the channel, in the sodium gated voltage channel. And it is a structural abnormality that modifies at a nano level. So I think that maybe we could always talk about structural when we are talking about genetic. I don't know if it could be considered.
Look, I think that's a very interesting point, and I think the more we can drill down on anything with higher resolution, as you say, down to the cell, down to the ion channel, there are structural changes. But this is practical, and it's about what you can find, and at the moment it's as good as you can find with current imaging that we have, which is MRI. The other issue is it may not always be structural, it may be functional, and I think ion channels are a nice example. Though, as you said, maybe if you looked at that ion channel at a very, micro scale, you would see that it was structurally abnormal. But that's really the basic science approach rather than the clinical approach. And what we need is something practical for us in the clinic. So yes, the more you drill down, the more these things get interwoven.
It's just to simplify it, because sometimes too much different etiology categories might confuse a little bit, but maybe, as you say, a genetic cause is a structural that can traduce in a functional or maybe in a metabolic abnormality. So we're fusing like 3 different etiologies.
But I think the issue about this, thinking about etiology, is management. And at the moment, if you have an ion channel mutation, you're not going to go out and cut out every ion channel of every cell. And that's really, you're talking down at that structural level, which is true, but is not practical. I mean, what we're looking at is a structural change on an MRI that may render someone a surgical candidate. It's a completely different level of question.
Yeah, I can see it.
Thank you.
Okay, Alex.
Hi. Hello. Yeah, Michael X from Austria is here. And I've got a question for the whole panel, I'm afraid, because as all of you said, that the information is available on the internet for everybody now. So all of the patients are aware of the new classifications, and some of them are reading those classifications before they're going to their doctor to see their doctors. And now they are afraid because they don't know what is focal and what is the other one. Is this the same or is it not the same? And on the social media, there are always questions raised. Is this the same or is this not the same? What can we do to raise this, to bring this information to the patients?
Okay, Michael, maybe I can answer for the panel. You brought up an excellent point. We are very well of that. And in fact, together, the ILAE and the IBE have prepared a document, yes, which will be put on the websites of the 2 organizations, will also be published and spread, and that is directed to the lay public, to the caregivers, to the families, to the people with epilepsy, in the way that they can understand with simple language what the 2017 classification is, and especially what are the differences and why those differences have been introduced. So well done, and we are taking care of that. Thank you.
Thank you very much.
Okay, so we have 2 more questions. I think Piers in the back there.
Hey.
Yeah.
Albert Colon from the Netherlands. Thank the captains for a very pleasant flight. It was rather nice in this bad weather. However, I disagree a little bit with the idea that stigmata are always wrong. There are cultural differences, I agree, but getting rid of the idea of catastrophic epilepsy means that in the management culture of my hospital, things will slow down. The catastrophic epilepsies were a bless for patients that needed to be helped fast. So why did you get rid of it?
That is pretty straightforward. We got rid of it because if you try and tell a family that your child has or adult has a catastrophic epilepsy, it's like, well, it's like saying you've got cancer. It's just terrible. Now, these epilepsies are horrendous, I agree, but I don't think it's a useful term to share with patients. That doesn't mean that we can't use it with our hospitals and use it to leverage rapid care, which is what I think you're suggesting is the issue.
Yep.
And I think, yes, they are catastrophic and devastating, but to actually deliver that as a name of a group to a patient, to a family, I don't think is a useful thing.
So one more question, please, before we finish.
Ingrid, to you, thank you very much for analysis of epileptic encephalopathies, because it's not simply problem. I think cases of epileptic supporting by clinical EEG methods diagnosis of epileptic encephalopathy should be named as epileptic disease without epileptic seizures. Someone for you, two remarks to your historical presentation. The first who was terms functional epilepsy, systemic epilepsy, sorry, was Peter Wolf for 4 years before Avanzini. And then about Todd, the second advance of Todd, maybe the first, he suggests that epileptic electric discharge is a consequence of chemical process in epileptic neurons. Thank you.
Okay, thank you very much. Thank to the speakers, and thank you all of you for attending this session.
Indeed. Thank you.